This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Conference. As you can see, our speaker this morning is Dr. Aditi Nayak. Aditi is one of our third-year fellows in our clinical investigator track. She is from India, did her medical school in India, came to the United States, did her residency at the University of Pittsburgh Medical Center, and did 2 years of research with Dr. Alana Morris. And as you can see, he's going to talk to us today about LVAD and sex differences and outcomes. So thank you, Aditi, and thanks again to everyone.
Hey everyone, good morning. Thank you for the introduction, Robbie. Today I'll be talking about sex differences in outcomes after LVAD implant. This talk references a lot of the research that I worked on during my 2 years as a research fellow in Dr. Morris's lab, where my primary focus was on elucidating the biological and social determinants of sex disparities in outcomes after LVAD implant, and the use of device innovation to mitigate these disparities. Now, I want to preface this by saying that while this is a research talk, I will try to make it as clinically relevant as possible and also reference our Emory data where possible. Now, the main learning objectives of my talk are to establish an understanding of what is known of sex differences in outcomes after LVAD implant, what factors mediate these observed sex differences in outcomes after implant, and finally, what are some potential interventions then that we can use to help bridge these observed disparities. So first, I'd like to start off with a patient that I saw during my EUH heart failure rotation, to whom the learning objectives of this talk may be applicable. So Miss CJL was a 39-year-old female, had HFrEF due to non-ischemic cardiomyopathy, thought to be due to idiopathic lymphocytic myocarditis, had an ICD in place, insulin-dependent diabetes, obesity, depression, and atrial fibrillation. She had worsening symptoms of volume overload with a concern for low output state in clinic. Her most recent echocardiogram showed an LVEF of 20 to 25%, grade 3 diastolic dysfunction, an LVEDD of 4.9 centimeters, an LV end systolic diameter of 4.6 centimeters, an LVOT-VTI of 15.8 centimeters, mildly reduced RV systolic function, trace TR, and severe MR. Her right heart cath, which was about 3 months old, showed an RA pressure of 14, an RV pressure of 58/15, a PA pressure of 49/31 for a mean of 37, a wedge pressure of 30, a transpulmonary gradient of 7, a diastolic pulmonary gradient of 1, a cardiac index by FIC of 1.79, SVR of 1,465, PVR of 2.03 Woods units, an RV stroke work index of 549, a PAPI of 1.3, and a CVP to pulmonary capillary wedge pressure ratio of 0.46. Her home medications were metoprolol 25, torsemide 100 QD, aldactone 25 QD, Eliquis 5 BID, and insulin. In terms of her psychosocial evaluation for advanced therapies, her primary caregiver was determined to be her mother. She was thought to be a good candidate for advanced therapies by her CPAT score, that is the Stanford Integrated Psychosocial Assessment for Transplantation score that we use to assess eligibility for advanced therapies. She was thought to be ineligible for heart transplant due to obesity, and she was basically admitted for destination therapy VAD evaluation and initiated on milrinone at 0.125. In terms of other relevant data, her BSA was 1.93, her BMI was 35.4, she was an Intermax profile 3, that is clinically stable but inotrope dependent. Her sodium was 136, BUN was 11, creatinine 0.65, Billy of 1.6, albumin of 3.8, hemoglobin of 12.6, a platelet of 275,000, and an INR of 1.6. Now, she had a relatively uncomplicated pre-op course and then underwent a HeartMate 3 implant. Out of the OR, she came out with speeds of 5,100 RPM, 3 liters per minute of flow, and a power of 3.5. Now, her post-op course, though, was complicated by RV failure, AFib with RVR, and multiple low-flow alarms. About 3 days after implant, and a TTE ramp study was performed for concern of RV failure. At 5,100 RPM, her LVEDD was 2.3 centimeters, her septum bowed leftwards, her aortic valve was closed throughout, she didn't have MR, and her RV was not well visualized. Her speed was reduced to 4,800 RPM. And at this speed, her LVEDD was 3.1 centimeters. Her septum was more midline. Her aortic valve was closed throughout, and she had no MR. I apologize that I don't actually have pictures because the echo quality was pretty poor, so I didn't see a point in actually putting those pictures up. Now, this was the first of many ramp studies and speed adjustments for Ms. CJL. She was discharged home after a 28-day length of stay and readmitted within 4 days for low flow alarms again. Now with that, let's dive into our first objective. What is known of sex differences in outcomes after LVAD implant? So to start off with a brief background, LVAD utilization and outcomes have improved since 2014. On the figure here on the left, you can see data from the STS 2020 Intermax annual report depicting LVAD implants by pump type. As you can see here, this green colored, the green colored pump type is basically the HeartMate 3. And you can see this by implant year since 2010. Now, after a temporary decline in the total number of continuous flow LVADs that were implanted between 2016 and 2017, implant volumes increased. And as you can see, we implanted a record number of continuous flow LVADs in 2019. Now, not surprisingly, the dominant design has become magnetic levitation technology, or the HeartMate 3, that accounted for 77% of all the devices implanted in 2019. Now, on the figure here on the right, you can see a Kaplan-Meier survival curve from the same report that compared survival for implants in the pre-contemporary 2010 to 2014 era in red with the 2015 to 2019 era, or the contemporary era, in blue. Now, what you can see here is that survival on LVADs has significantly improved since 2014. We're now looking at an 82% survival at 1 year, 73% at 2 years, with almost half of these patients alive at 5 years after implant. Now, while that's exciting news, large registry analyses do demonstrate that sex differences in post-LVAD outcomes exist. Now, here you can see a table from the 8th annual Intermax report that includes data on more than 20,000 patients from more than 180 hospitals across North America that were implanted between 2006 and 2016. Female sex was independently associated with a 47% increased risk of early 3-month post-LVAD mortality in fully adjusted models. Now, interestingly, this entire increased risk occurred only in the first 3 months after implant, but not after. Now, this is slightly older data from Euromax that analyzed 966 patients in the Euromax registry, or the European registry, who were implanted between 2011 and 2014. Now, this figure on the left represents cumulative incidence function curves accounting for the competing risks of death, transplant, and recovery in male and female LVAD recipients. Again, here you can see in red the mortality curves, and you can see that females have a worse mortality than males, even after accounting for all of these competing risks. In this report, only 37.2% of females were alive at 2 years compared to 53.3% of males. Now, again, this is older data from the pre-contemporary era. Now, there is a paucity of data on sex differences in outcomes in HeartMate 3 LVAD recipients. However, in this analysis of UNOS data from 2008 to 2018 that included 365 HeartMate 3 recipients, D. Philippus and all found worse outcomes for female bridge to transplant LVAD recipients independent of device type. Again, here you can see these cumulative incidence function curves with the solid lines representing mortality for females in red and males in blue. Incidence of death for females was 5.2% at 1 year versus 2.7% at 1 year in males. At 4 years, this was 12.1% in females versus 7.1% in males. Now, that's almost a double risk of mortality in females compared to males. Females also had a lower chance of heart transplant in this analysis. So now what about LVAD-related adverse events? Now, unfortunately, the story doesn't get better here either. If there's one thing that's drilled into our heads during the EUH heart failure rotation, it is that LVAD-related adverse events continue to be the Achilles heel of LVAD therapy. 70% of LVAD patients experience a major adverse event at 1 year. Readmissions are 38.6% at 90 days and 72.2% at 12 months. At any given time, about 25% of all LVAD patients are admitted in a hospital in the United States. Now, female sex is associated with an increased risk of most of these adverse events, including major bleeding, especially GI bleeding, RV failure with need for additional RV support, CVAs, as well as arrhythmia events. Now, I'd like to highlight some Emory data in this space. Dr. Morris, back in 2015, utilized the Emory LVAD database to study differences in the incidence of stroke. Now, in this paper, stroke was defined as both ischemic as well as hemorrhagic stroke. What she found was that the risk of stroke was 3.1 times higher in females than in males. Now, even in fully adjusted models that included INR time in therapeutic range, female sex continued to be a risk factor for stroke. Now, this figure depicts competing outcomes of stroke and deaths in males versus females. And again, here you can see in red that females had a much higher risk of stroke than males. It's also important to note here that the interaction between sex and LVAD type was not significant, indicating that the association of female sex with stroke did not vary based on whether the patient had a HeartMate 2 or an HVAD, which were the two devices that were being implanted at that time. But one thing you may have noticed is that all of the studies I've presented thus far have included a lot of data on LVAD implants in the pre-contemporary, pre-2014 era. So a major question that we had was, do these sex differences in post-LVAD outcomes persist in the contemporary LVAD era where we're otherwise seeing such improved overall outcomes? So to answer this question, we utilized contemporary multinational data from the IMAX database, or the ISHLT Mechanically Assisted Circulatory Support database. Now, I'd like to explain this database in a little more detail because I will be referring to it several more times during the course of this talk. Now, IMAX data pulls data from Intermax, Euromax, the Japanese registry for mechanical assisted circulatory support, the United Kingdom registry, as well as 24 independent hospitals across the globe. So a total of 35 countries are represented, as you can see here on the map on the left of your screen. Now, the database includes 15,498 adult continuous flow LVAD patients that were implanted between January 2013 and September 2017. So what we found was that female sex is associated with higher post-LVAD mortality in this IMAX database as well. Furthermore, what we found was that there was a significant sex-time interaction, indicating that the association of female sex with increased mortality varied with time after implant. An early period of increased risk was identified, with females experiencing a 74% higher risk of mortality during the first 4 months after implant, but similar risk to their male counterparts after that. Now, this restricted cubic spline in this figure from our manuscript depicts the varying mortality hazard ratio for female sex over time since implant. And what you can see here is that the lower confidence interval crosses 1 at about 4 months. This again is a fully adjusted analysis, adjusting for all pre-implant covariates that are known to be associated with mortality after implant. Next, we looked at primary cause of death in the first 4 months after implant by sex, and we found that the cause of death also varied by sex. Females were more likely to die of neurological dysfunction or strokes in the first 4 months after implant, and males were more likely to die of multi-system organ failure. So with that, I come to my first take-home point for this talk, that female continuous flow LVAD recipients have worse mortality and higher risk of LVAD-related adverse events than do males. So our next question and our next objective is, what factors mediate these observed sex differences in outcomes after LVAD implant? Now, it's a known fact that sex impacts almost every facet of heart failure, from risk factors to pathophysiology, from phenotypes and outcomes, including quality of life. Now, the exact underlying mechanisms are poorly understood, but likely represent this complex combination of biological, psychosocial, hormonal, and systemic causes. Now, for example, the higher risk of heart failure with reduced ejection fraction in men compared to women has been attributed to their predisposition to macrovascular coronary artery disease and myocardial infarction, which are known precedents to heart failure with reduced ejection fraction. Now, conversely, coronary microvascular dysfunction has been postulated to play a major role in heart failure with preserved ejection fraction, and may be the common link amongst different heart failure syndromes that women are more predisposed to, like HFpEF, Takotsubo's, or peripartum cardiomyopathy. Now, even less is known about the mechanisms underlying sex differences in advanced heart failure and post-LVAD outcomes. But some potential mediators that we have explored as a group can be grouped into these three different factors: systemic factors, biological factors, and psychosocial factors. Now, I'm going to go into each of these in a little more detail. Now, first, to go through some systemic factors, females are diagnosed and referred for advanced heart failure therapies later in the course of their disease. Now, this may be because of atypical disease presentation in females or implicit bias on the part of providers. Females are less likely to be prescribed guideline-directed device and medical therapy as well. Now, again, to highlight some Emory data in this space, we utilize the Emory database of all patients evaluated for advanced heart failure therapies. Now, this was a total of 569 patients that we evaluated between 2012 and 2016. And what we found was that females were more likely to be deemed ineligible for advanced therapies, specifically for heart transplant or bridge to transplant LVAD. Here you can see in this figure excerpt from our manuscript that 54.5% of all evaluated females were found to be ineligible for advanced therapies versus just 43% of males. So we then looked at primary reasons for ineligibility for heart transplant by sex in these patients. What we found was that females were more likely to be ineligible due to allosensitization and obesity. However, adjustment for both of these factors only mildly attenuated the association between female sex and ineligibility for advanced therapies, indicating that there may be other factors at play. Now, importantly, we did have pretty granular psychosocial data, including readiness for advanced therapies, social support, and psychiatric stability. And we did not find that these were significant contributors to differences in eligibility. Next, let's look at some potential biological factors underlying these sex differences in post-LVAD outcomes. Now, interactions between the hormonal environment, estrogen in females, higher inflammation in females, smaller anthropometry in females, sex differences in expression of genes, as well as clustering of different risk factors contributes to differences in myocardial structure, cardiac metabolism, as well as vascular dysfunction. Now, for example, females have smaller ventricular chambers as well as lower diastolic compliance. In terms of cardiac metabolism, they have higher myocardial blood flow and oxygen consumption. In terms of vascular dysfunction, for example, they have more abnormal ventricular arterial coupling, more pulmonary vascular reactivity, and remodeling. Now, some or a combination of all of these factors could contribute to these observed sex differences in post-LVAD outcomes. Finally, let's look at some potential psychosocial factors that could underlie these sex differences in post-LVAD outcomes. Now, psychosocial and socioeconomic determinants of cardiovascular health have a greater impact on females than males. Fewer females live with spouses or work for income, resulting in females being more likely to experience cost-related issues with health insurance and medications. Depression, as we all know, is more prevalent in females and is a significant predictor of adverse cardiovascular outcomes. Now, lack of adequate caregiver support and psychosocial risk are considered relative contraindications to advanced heart failure therapies. However, in a recent paper, Breedhead and colleagues found that these social support assessments are perceived by providers as more critical for women than men. They performed a qualitative study of 46 US clinicians in 2019 who were attending an advanced heart failure conference. Of this, 52% were female, 43% were a racial minority, 67% were cardiologists, and 15% were cardiothoracic surgeons. These clinicians were randomized to otherwise almost identical clinical vignettes with accompanying photographs of an African-American woman and man and a white woman and man. The participants were masked to study objectives and interviewed about their decision-making process on allocation of advanced heart failure therapies. What they found was that the appearance of women was critiqued more harshly, and there were greater concerns of adequacy of social support in women. This is although the clinical vignettes gave exactly the same picture of social support for both the man as well as the woman. Now, I've highlighted some illustrative quotations here. So, for example, reacting to a participant photographs, a quote about an African-American woman was, "I would say she looks so anxious." That might be off-putting, but I've seen, sorts of patients in her situation. Regarding the perceived care of childcare, regarding the perceived burden of childcare, a quote about a white woman was, "She has 2 children dependents and they're not old enough to be truly helpful. And actually, they're a liability in terms of being sick." Now, children are perceived as liabilities for women, particularly African-American women. Spouses were deemed more inadequate support for women than men. Family dynamics and finances were greater concerns for African-American women. Now, there was no association between gender and race and final recommendations on allocation of therapies, but this could still play a role in the real world in delayed allocation of therapies to women. Now, building off this background, we again utilized the Emory database of patients evaluated for advanced heart failure therapies, 674 patients evaluated between 2011 and 2017. We found that females in our database were less likely to have a spouse and more likely to have a parent or a child listed as a primary caregiver. There was a trend towards worse psychiatric stability scores, or the CPAT subscale C, for females. Now, again, this did not impact differences in eligibility for advanced therapies in our cohort, but could have impacted delayed allocation of therapies, which contributes to women being sicker when they're actually seen for advanced heart failure therapies. Now, to determine which of these potential factors actually mediates the observed increased risk of mortality for females after LVAD, we performed a causal mediation analysis testing plausible pre-implant mediators that were collected in the IMAX database. Now, these plausible mediators can be categorized as differences in cardiac structure, psychosocial factors, pre-implant management, as well as other miscellaneous factors. Now, under cardiac structure, we looked at LVEDD, moderate to severe MR, TR, AR, as well as qualitative RV function by echocardiogram pre-implant. Under pre-implant management, we looked at the presence of an ICD or CRT, RAS blockade. At this time, because this was pre-2017 data, Entresto was not widely used at that time. In addition, we looked at beta blocker, MRA, inotropes, and amiodarone prescription prior to implant. We also looked at psychosocial factors of major depression, other psychiatric disorder, education status, and marital status. And other miscellaneous factors we looked at were years since heart failure diagnosis, as well as a history of solid organ cancer. Now, what we found was that of all of these potential mediators, only differences in cardiac structure mediated the increased risk of early mortality in females in the IMAX cohort. Specifically, smaller LVEDD and more TR in females mediated about 22% of the increased risk of mortality in females. Now, of these two, LVEDD explained a majority of the risk, accounting for nearly 18% of the increased risk of early mortality in females. Now, prior studies have demonstrated an association with smaller LV size and worse post-LVAD outcomes. So, for example, in this study, Topilsky and colleagues studied 83 continuous flow LVAD patients to demonstrate that a smaller LVEDD that they defined as less than 6.3 centimeters in this study was associated with a higher 30-day risk of mortality after LVAD implant, as you can see in this Kaplan-Meier curve from their manuscript. Similarly, in an Intermax analysis as well, Shah et al. Found 11% increased hazard of post-implant death for each centimeter decrease in LVEDD. In addition, several prior studies have demonstrated an increased risk of stroke and GI bleeding when LVADs are implanted into smaller LVs. Now, what could be the underlying hemodynamic mechanism for this? Now, one obvious reason that comes to mind is that surgical implantation into a smaller LV is more technically challenging. However, our group's primary hypothesis based on prior literature is that a smaller LV predisposes to LV size LVAD pump speed mismatch. Now, as a result of this excessive LVAD support, leftward interventricular septum displacement occurs, and this leads to a disproportionate reduction in LV volume and filling pressures. Now, this excessive septal shift then increases RV wall stress due to an increase in RV diameter by Laplace's law. Increased RV wall stress then can reduce contraction efficiency, leading to worsening tricuspid regurgitation, reduced RV stroke work, and then RV failure. In addition, hemolysis, thrombus formation, myocardial injury, and arrhythmias can occur if the IVS contacts the LVAD cannula. Now, to test this hypothesis of ours that a smaller LV size predisposes to this LV size LVAD pump speed mismatch, and that this then induces adverse leftward IVS shifting, we adopted a bedside to bench approach. We collaborated with a translational engineering group based out of Stanford to test this in 4 silicon patient-specific heart phantoms. These were created from gated CT-derived measurements at end diastole. Now, smaller hearts were represented by phantoms with LVEDDs of 6.1 and 6.3 centimeters, and larger hearts by LVEDDs of 8.1 and 8.3 centimeters. We used an ultrasound transducer to derive measurements of real-time interventricular septum positioning, and measurements were obtained at different LVAD unloading states. Now, these different LVAD unloading states were mimicked by removing volume from the LV in 10 ml increments and adding volume to the RV. Now, on the left over here, you can see our test bench setup with the cardiac phantom, the apparatus for adding and removing volume from the LV and the RV, as well as the ultrasound transducer that was placed inside the LV cavity. Now, what we found was that the interventricular septum of smaller hearts abnormally shifted to the left at smaller volume changes, that is lower LVAD pump speeds than in larger hearts. So we were able to conclude that the interventricular septum of smaller hearts is more sensitive to LVAD pump speeds than larger hearts. And you can see this depicted on the figure below from our manuscript. You can see the larger hearts represented in orange and the smaller hearts represented in blue. And what you can see is that the interventricular septum shifts to the left at a smaller volume change in the blue hearts. So with that, I come to my take-home point number 2, that cardiac structural differences, particularly smaller LV size, mediates about 1/5 of the increased risk of mortality. However, a majority of this increased risk is still unexplained. Now, finally, coming to our third objective, what are some potential interventions to help bridge these observed disparities? First, I'd like to sort of preface this by saying that all of these potential interventions are suggestions based on what we know of sex differences in post-LVAD outcomes so far. Now, of course, as further research comes out in this space and the underlying determinants of these disparities are more understood, there will be more interventions to bridge these disparities. Now, our potential interventions can be grouped into 3 different types of approaches: clinical approaches, engineering approaches, and of course, research approaches to address these current knowledge gaps. So first, let's look at some clinical approaches. Now, one easy approach may be protocolized earlier and more frequent ramp study LVAD pump speed adjustments in the first 3 months after implant in females. Now, is there a role for 3D echo guided ramp studies to measure septal curvature with speed adjustments? There was a recent study that came out of the group in Colombia that actually made an algorithm to calculate septal curvature based on 3D echo measurements for these ramp studies. Another simple approach would be to index LVAD pump speeds for body surface area, as well as the avoidance of excessive LV offloading by overdiuresis in females. Now, another area of importance that our group has done some work on is sex-specific prognostication in pre-LVAD patients. Now, this is particularly important as several of the commonly used prognostic risk scores throughout the spectrum of heart failure, from the Seattle heart failure model to the HeartMate-2 risk score that's used for pre-LVAD prognostication, were actually derived and validated in predominantly male cohorts without testing for any interaction effects with sex. So sex-specific prognostication would aid in patient selection, as well as help us have shared informed decision-making with our female patients. So our group has utilized the IMAX database to create and validate a sex-specific risk score for the outcome of early post-LVAD mortality. Now, the reason we developed the IMAX risk score for this outcome is that this is the period of unexplained increased residual risk in females, like we had earlier discussed. Now, we considered 21 candidate predictors spanning demographics, index hospitalization events, pre-implant biochemical and hemodynamic data, echocardiogram, and psychosocial data. We studied interaction effects with sex and also report sex-specific model performance. Now, these were the 13 variables that made the cut for the inclusion in the IMAX risk score. They were age, heart failure etiology, that is basically ischemic versus non-ischemic, BMI, a cardiogenic shock at implant or intermax profiles 1 and 2, major infection pre-implant, dialysis pre-implant, hemoglobin, platelet count, BUN, total bilirubin, albumin, moderate to severe TR, and LVEDD. Now, all of these are routinely collected pre-implant variables. Importantly, 2 of them, specifically heart failure etiology and platelet count, had sex-specific effects. Ischemic cardiomyopathy was associated with worse outcomes in females, but not in males. And lower platelet count was associated with worse outcomes in females, but not in males. Now, the removal of these interaction terms with sex resulted in a significant loss in model fit, indicating that these sex-specific effects are actually critical to accurate prognostication in this population. Now, the IMAX risk score demonstrated better risk discrimination than both the HeartMate-2 risk score as well as the MELD score in both males and females, in both the derivation and the validation cohort. Now, this table demonstrates an improvement in prediction in terms of AUC, NRI, and IDI over the HeartMate-2 risk score. In addition, the IMAX risk score demonstrated excellent risk calibration with essentially no difference in observed and predicted risk in both males and females. When divided by sex-specific quartile, you can see here that the observed and predicted risk track very well with each other. There was an 86% increased risk in males for each quartile increase in the IMAX risk score, and a 93% increased risk in females for each quartile increase. Now, the risk calculator is actually available online for easy clinical use on this website, and I would encourage everyone to use it where possible. Now, coming back to Miss CJL, in case anyone was wondering, her IMAX risk score would have given her a 19.3% increased risk of mortality in the first 3 months after implant. So she would have been a high-risk patient coming out of the OR. On the other hand, the Heart-Mate-2 risk score would have given her a less than 5% risk of 3-month mortality, i.e. she would have been a low risk coming out of the OR. Next, let's talk about, really briefly, some simple engineering approaches to help improve these outcome disparities. Again, in collaboration with our engineering group at Stanford, we envision device innovations where sensor technology is integrated into the LVAD cannula. Breakthroughs in micro-machined ultrasound transducers enable the integration and miniaturization of ultrasound technology. These integrated ultrasound transducers could monitor the IVS position or the interventricular septum position in real time for automatic pump speed adaptation. Now, the study that I referenced from our group earlier utilized an ultrasound transducer that is equivalent to a probe with 156 individual transducers, so would generate a large amount of data if used in real time. However, a recent study by our collaborators demonstrated 80% accuracy in predicting septum position with only 3 transducers. Finally, I'd like to end by pointing out some areas of future research to address current knowledge gaps. There needs to be increased female recruitment in clinical trials, as well as reporting of sex-specific clinical trial data. We need to better understand female-specific risk factors, as well as the underlying mechanisms for these observed sex disparities. A study I'd like to highlight is the Emory VADomics study, in which we've collected blood and urine samples on patients pre and post LVAD. We plan to use these samples for metabolomics and transcriptomics analyses to uncover biological pathways that underpin these observed sex differences in post-LVAD outcomes. So with that, I'd like to end with my final take-home point, that concerted clinical and engineering approaches coupled with research aimed at elucidating underlying biological and social determinants are necessary to bridge this observed sex disparity in post-LVAD outcomes. So I'd just like to reiterate the 3 major take-home points from this talk. I know I spoke a lot. The first take-home point is that female continuous flow LVAD recipients have worse mortality and a higher risk of LVAD-related adverse events than males. Cardiac structural differences, particularly smaller LV size, mediates about 1/5 of the increased risk of mortality. However, a majority of the increased risk remains unexplained. And finally, concerted clinical and engineering approaches coupled with research aimed at elucidating these underlying biological and social determinants are necessary to bridge the observed sex disparity in post-LVAD outcomes. Thank you for listening. I'd like to acknowledge my mentors and collaborators across multiple institutions. Of course, Dr. Morris and Dr. Kayumi over here at Emory, Dr. Simon at UCSF, Dr. Kormos at UPMC, Dr. Kauger at Henry Ford, and Dr. Dual, who is our primary engineering collaborator at Stanford. And with that, I'm happy to take any questions.
Aditi, thank you. Good, excellent talk, and some certainly interesting concepts and things to think about. I guess my question is, in other areas of cardiology, when you look at worse outcomes in women, particularly in the coronary disease literature, it often seems to come down to increased bleeding risk in that group in women. What you mentioned it, sort of, you touch on it briefly a little bit here and there, but what factor do you think that plays in these worse outcomes, the bleeding, given that these patients are anticoagulated, et cetera? What kind of role do you think that plays?
Yeah, I think that is an excellent question. And I think more research needs to be done in that space. I know I went through a lot, but I don't know if you caught that we actually found that platelet count and female sex have an interaction, i.e. that low platelet count is associated with worse outcomes in females and not in males. So from a talk that I gave earlier this year, I actually have an appendix slide that may answer your question a little bit. Yeah. So there is an increased risk of major bleeding in females after LVAD implant. What's interesting is that platelet counts, aggregation, reactivity, and response to antiplatelet therapy are all sex dependent. So we definitely need more research in this space. And there's a question, are sex-specific antiplatelet regimens needed to, sort of optimally balance this bleeding risk in LVAD recipients? I mean, unfortunately, there's not much work in this space, and that's why disparities research is really cool. But yeah, this is all I could find.
No, it's good that you had a slide ready for my question. I'm impressed.
This is part of, I gave a part of this talk in AHA last year, so I can't take credit for it. I
think one of the things, this is Alana, I think one of the things that makes it difficult to answer these questions, period, is because the technology in this space moves so rapidly. I mean, we're asking the question right now of whether or not any patient with a VAD, male or female, requires aspirin at all. We're participating in a trial right now called the Aries trial, asking the question of whether or not these patients need aspirin. So this space is moving so rapidly in general, in terms of the way that these devices change, the way that the engineering changes, and then trying to keep up with that and ask the question of whether or not there are sex-specific differences. I think that's one of the things that makes doing disparities in this space particularly challenging.
Okay, well, again, excellent talk, Aditi. Again, some interesting concepts to think about. Obviously the smaller LV cavity size makes sort of intuitive sense, but something I had, clearly we read a lot of these echoes in our echo lab at Clifton Road, but it's certainly not something I'd ever paid attention to. It's something I'll certainly be looking at when we're looking at these patients' echoes moving forward, looking at LV sizes, that sort of thing, and septal, paying more attention to septal curvature, et cetera. So thanks again, everybody. Thanks, Aditi.
The preceding program is copyrighted by Emory University.